Welcome to all of you this evening to the meeting of the Board of Directors of the Washington Township Healthcare District. I'd invite you all to stand with me and join in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Christine, if you take the roll for us, please.
Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Eben.
Thank you. Our first item of business will be a consideration of Resolution 1150. It's a certificate of the November 4th, 2014 general election for the Board of Directors. Dr. Nicholson.
Mr. President, I move for adoption of Resolution Number 1150. The title reads as follows. Resolution Order of the Board of Directors of Washington Township Healthcare District, acknowledging the appointment of Bernard L. Stewart, Jacob Eben, and Michael J. Wallace as directors of the Board of Directors of Washington Township Healthcare District. If you'd like, I could read the whole resolution if you prefer.
I think we can dispense with reading the whole thing. That's a very nice resolution.
It's a delightful resolution. Does it have a second?
Is there? We have a second on that. Is there any discussion from the board?
You might just explain why the appointment, as opposed to the election.
Yes. This complicated document that Dr. Nicholson has just read certifies that in the November 4th election, 3 of the board members were up for re-election. And in that election, all 3 of us, Mr. Wallace, myself, and Dr. Eben, were unopposed. And so you did not see our names on the ballot, which was a very thrilling thing for us because it meant we didn't need to run a full campaign. It also I believe, is a vote of confidence for what has been accomplished in the past and for each of us. Kind of a nice thing to not be opposed. At any rate, that resolution affirms that the 3 of us were essentially re-elected in that campaign. And tonight, we need to take the oath of office for a new term. The term of office of a member of the Board of Directors is 4 years. So we're essentially signing up tonight for 4 more years. We have with us tonight, very nice, the Honorable Judge Ron Sabra is with us, and we really appreciate his being with us tonight to give the oath of office to each of those of us who were re-elected. So if we could have...
Mr. President?
Oh, I'm
We actually have
sorry.
to take action.
I was so excited about that. So excited about that, I forgot we had to vote. We have a motion, we have a second. It's a great resolution. Christine, if you would take a vote.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Eben.
We have a unanimous vote that passes. Now, Judge Sabra.
Thank you, Dr. Stewart. We're going to have the oaths administered beginning with Dr. Stewart, followed by Mr. Wallace, and followed by Dr. Eben. And Dr. Stewart, if you'll raise your right hand and repeat after me. I state your name.
I, Bernard L. Stewart,
Solemnly swear
solemnly swear
that I will support and defend the Constitution of the United States
that I will support and defend the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully discharge
and that I will well and faithfully discharge
the duties upon which I'm about to enter.
the duties upon which I'm about to enter.
Congratulations.
Thank you.
Doctor, and I'm going to have you sign right.
Good job.
And next, Mr. Wallace. For you, Mr. Wallace, and for me, this is reprise number 4, I think, or some, or 6. It's funny, you haven't aged at all. I myself am a little grayer than I used to be.
You're fishing for compliment.
You would raise your right hand. I state your name,
I, Michael John Wallace,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United
the
States
Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully discharge
and that I will well and faithfully discharge
the duties upon which I am about to enter.
the duties upon which I am about to enter.
Congratulations, Mike.
Thank you.
Here you go. And Dr. Reed. Welcome. Doctor, raise your right hand and repeat after me. I state your name.
I, Jacob Eapen,
Solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California.
and the Constitution of the State of California,
That I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California.
and to the Constitution of the State of California,
That I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion.
or purpose of evasion,
That I will well and faithfully discharge
that I will well and faithfully discharge
the duties upon which I'm about to enter.
the duties upon which I am about to enter.
Congratulations.
Thanks.
Thank you, Doctor. Thank you.
Again, I'd like to thank you. It's wonderful for you to take some time to be here. It's wonderful to see you again. Hope to see you again in 4 years. Thank you for
Could
being
you get a
here.
photograph of the judge and
Yes, if
the
the
members of
audience
the
would
board?
bear with us for just a few minutes. This really is a nice event for all of us. All of us feel very, very dedicated to the hospital and to the community. And it's a wonderful opportunity to be able to serve again for 4 years. We'd like to just take a moment to get our picture with Judge Sabra, and then we'll resume the meeting. We'll take just a brief break for that. The next item of our business tonight is the election of officers. Every December, we elect new officers of the Board of Directors. And so tonight, we'll be considering election of a new slate of officers for the Board of Directors. And I've asked Mike Wallace if he would present that action item.
Yes, Dr. Stewart, I would like to propose that the nominations are as follows: Pat Danielson for president, myself as first vice president, Dr. Nicholson as second vice president, Dr. Stewart as secretary, and Dr. Jacob Eapen as treasurer.
Do I have a second on that?
Second.
Any discussion that we need to make on that? I'm anxious for any consideration. There being none, then we'll call for a vote on that. Christine?
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Dr. Danielson.
Aye.
Director Eapen.
We have a unanimous vote on that. That means that I get to move places and retire. I'll take it. I can take all my toys.
You're not getting my seat.
Okay.
You're not getting my pillow.
Thank you.
Oh,
So you come up.
No, it's higher than, that's okay. If I get altitude sickness, let me know. Okay? Hello, everyone. I would like to thank the board members for having confidence in me to elect me president again. So thank you very much, gentlemen. I'll do my best to lead us this year. Thank you very much. So let's get on with the agenda, and I see that we have an education session on AB 1234, ethics training.
I'd like to introduce our speaker. I think all of you know Kristen. Kristen Ferguson graduated from California State University in Hayward in 1990 with a bachelor's degree in human biology and a minor in public health and public speaking. She spent 14 years working in the technology industry as a software sales rep and as a director of sales. In 2004, she entered nursing school at Ohlone College and came to work at Washington Hospital, working as a program coordinator for the internal medicine hospitalist program. In 2006, Kristen graduated from nursing school and began her nursing career as a staff nurse at Washington Hospital. She worked in various leadership roles over the next 6 years as a charge nurse and as a bed management nurse. In 2011, Kristen was selected to participate in a 1-year administrative intern program, working under the leadership of the Chief Executive Officer and the Associate Administrators. In 2012, she graduated from UOP with a double master's degree in nursing and healthcare administration. In May 2014, Kristen became our Chief of Compliance. She's also certified in healthcare compliance. And with that, I hand the program to Kristen.
Thank you, Nancy. Good evening. California state law requires that elected public officials receive ethics training every 2 years. So this evening, I am going to be talking to you about Assembly Bill 1234, also known as AB 1234, and how it specifically addresses our board of directors. Our compliance to this regulation here at Washington Hospital starts with our Code of Professional Conduct. The hospital has a very detailed code of conduct, and it is a requirement for all who work and practice at Washington Hospital, including our employees, our medical staff, and our volunteers. And the code of conduct specifically speaks to the board of directors. In addition to this education session tonight, the board will also be required to participate and complete an online education course on the topic of ethics. Another thing we do here at Washington Hospital is have ongoing discussions about the topic of ethics. And we present information about ethics in various types of presentations, such as the one I'm presenting to you this evening. So the basis of all of this is set on a set of basic ethical principles for public service officials. And they really are quite simple. They are fidelity to the mission, responsibility to the community that the public official serves, and the principles of fairness, loyalty, trustworthiness, and respect. So from these principles come a set of public service ethic laws. The laws are quite complex. There are many of them, and there are many facets of the laws. The laws do represent a minimum standard that a public official must adhere to. And very important to remember is that the public official's first obligation is always to the service of the community they are serving. So I'm going to address this tonight based on 4 major categories of these ethics laws, and they are laws related to personal gain, laws related to personal advantages or the concept of perks, government transparency laws, and laws related to fair processes. So the first is the issue of personal financial gain. And the underlying principle here is this is about public service. Probably the most well-known issue is that of bribery, and there is an entire set of laws related to this subject. By definition, bribery is something offered or given to someone in a position of trust in an attempt to influence or persuade. It is a crime to solicit or receive benefit in exchange for official actions, and it's important to remember that benefit is not just cash or money. It can also include things such as jobs or special considerations, such as a permit or a license or something else that somebody may want. A key issue in the whole idea of personal financial gain is that of conflict of interest. And there is a fundamental principle as it relates to conflict of interest that comes from a California court case, and that is that public officials and designated employees must exercise absolute loyalty and undivided allegiance to the best interests of the entity and not themselves. So the concept of conflict of interest is embodied in the Political Reform Act, which was adopted in 1974. Conflict of interest is also discussed in the Fair Political Practices Commission regulations. There are 4 components of a conflict of interest, all of which must be present in order for a conflict to exist. The official must have a financial interest. The conflict must be reasonably foreseeable. There has to be a material financial effect of the relationship, and it has to be distinguishable from the effects on the general public. So, if everybody has the same opportunity, it's probably not distinguishable, and therefore probably is not a conflict of interest. The information here on this slide is especially helpful for you. There are 6 types of economic interests, so when you consider whether or not a conflict of interest exists, you want to ask yourself if the matter involves someone that pays you an income, property that you own or lease, your employer, one of your investments, someone that has given you a gift, and your family's finances. And you probably recognize these 6 categories because they are reflected on the Form 700, which is the disclosure of economic interest that the Board of Directors and certain members of the hospital community must complete on an annual basis. The regulations related to conflict of interest compel impartial performance, meaning you must be free from bias. They require disclosure of certain financial holdings based on the Form 700. And on this form, a public official is required to declare any conflicts they may have. And it's important to remember that in a meeting, if a conflict is identified during the meeting, it must be declared and it must be recorded in the meeting minutes. The regulations also require disqualification from discussion or deliberations and voting on a conflicted issue in order to avoid conflicts. And the issue here is the belief that it is possible for someone's simple presence in a room can impact another person's decision making. It's also important to remember that the conflict of issue is not actually the issue. It is indeed what the official then does in terms of disclosing and acknowledging the conflict. The other thing the regulation does is require a conflict of interest code, which we do have here at Washington Hospital. So best practices as they relate to personal financial gain. Be aware of the type of economic interest that can trigger these 6 categories and the need to possibly step aside in a decision-making process. And make all decisions with only the public's interest in mind, not based on your own personal interests or based on the interests of a member of your family. So the second category is what's called the no perks laws. And the underlying principle here is public servants should be treated like anyone else. A public servant should not require special benefits simply because of the office they hold. So perks that others give you, things such as gifts, travel, honoraria, etc. The considerations here are the need for reporting gifts on an economic disclosure, remembering that there are gift limits in a 12-month period, possible disqualification from discussions or voting based on a gift you may have received, and the option of declining gifts, returning gifts, donating them, or reimbursing the giver of a gift. There is a second category of perks that officials can, quote, give themselves, such as the use of public resources. It's important to remember that personal and political use is strictly prohibited, such as the use of public resources. So you cannot use things such as telephone systems and computer systems or the letterhead of an entity. And important here is the issue of knowing and understanding that we do have an expense reimbursement policy and the need to follow the policy very carefully. So best practices as they relate to perks. You want to avoid anything that might be considered a perk. And again, this is not an easy law to understand. So if you have questions of whether something is acceptable, I encourage you to seek counsel and advice for questions on matters that you are unclear about. The third category is governmental transparency laws. And the underlying principle here is the public trusts a process that it can see. Conversely, the public is not going to trust something they are not privy to. So the recommendation here is to provide the public with the opportunity to participate and monitor. Regarding economic interest disclosure, again, this is a requirement of the Political Reform Act. Here again is the issue of the Statement of Economic Interest, or the Form 700, and it is required by elected officials and designated employees at specific times, such as when an official takes office annually and when an official leaves office. Another issue here is the idea of charitable fundraising disclosure. The public has the right to know who is contributing to an official's favorite charity or causes. But it is also important to note that donations that are made to charitable foundations by a giver can indeed remain confidential and anonymous if so desired. As you are aware, there is a law called the Brown Act, which establishes the requirements for public meetings. The Brown Act requires open meetings to assure that the public is informed of decisions that public officials are making. There are some permissible gatherings where the board can indeed meet together, which include things such as conferences, community meetings, and social events. And also, as you know, the Brown Act does provide for closed sessions of the board. And this is all really based on the public's right to participate and be heard, and gives us such requirements as the requirement of posting meeting agendas for the public. There is also the public's right to access records, and Washington Hospital does have a policy which is in compliance with the Public Records Act. So best practices as they relate to governmental transparency laws. You want to follow regulations very carefully, and you probably want to err on the side of openness. So lastly, let's talk about fair process laws. And the underlying principle here is everyone has the right to be treated fairly by governmental processes. Related to fair and unbiased decision-making, the requirement is to exercise power that is free from personal bias, and that decisions not be related to the probability of either financial gain or financial loss. And again, here is the issue that disqualification by a public official can indeed resolve the issue. A part of the fair process law is the doctrine of incompatible offices, and this is based on the belief that there could be a significant clash of duties or loyalties if an official holds more than one office. The penalty for this can be the forfeit of the first office, so this is something very important for you to think about and consider if you are asked to participate in another official capacity. This is also where we see the competitive bidding requirements. These requirements assure equal access and avoids the concept of cronyism in granting work at a public entity. The requirements also assure that the public receives the very best value for its money and requires published bid notices for work at public entities. Another piece of fair process law is the issue of nepotism, and there have been several occasions over the years where we've heard in the news something about a public official granting a job to a family member. When it comes to making decisions involving family members, anti-nepotism laws are important to think about. They are required by the Political Reform Act, and they are based on the belief that it is very difficult to be fair and unbiased when you are dealing with a member or members of your family. And also important here is to remember that a public official's loyalty that is always to the entity that he or she serves first, and not to a member of one's family. So best practices as they relate to fair process laws. You want to consider all information on a subject in a fair and unbiased way before making a decision. So, just a couple of closing thoughts for you this evening. As you know, public officials are stewards of the public's trust. And earning and holding that trust is based on careful attention to ethical principles and to the public service ethics laws that I presented to you this evening. And finally, remember that ethics training is and always has been for this board of directors an ongoing process. Any questions? Thank you.
We now have the minutes of November 12th, 17th, and the 24th for consideration. May I have a motion, please?
Yeah, Madam President, I move for adoption of the minutes of November 12, 17, and 24, 2014.
Second?
Second.
Christine, would you take?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Egan?
Motion passes. Thank you. We are now in the communications section of our agenda. And I believe we have several speakers, but before we do that, I have a statement to read. Tonight, we anticipate hearing concerns about premium pay, and we are definitely prepared to listen. However, in previous meetings, we've seen people and groups trying to gain favor about their particular issue by attempting to attack the CEO's compensation. It is important, as president of the board, that I clarify that this board sets the CEO's salary through a transparent process held annually and presented during a board meeting just like this one. Just as the salaries of our employees are determined in part as a result of a thorough review of market data in terms of what other hospitals pay their employees and nurses, we use similar data to determine our CEO's compensation. Separately, the public comment period is a time for members of the community, which may include hospital employees, to present important issues to the board. The board will actively listen to these important issues, but we do want to make the distinction between these issues and that of the CEO's compensation. With this in mind, I believe our CEO has a statement to make. Nancy?
Thank you, Pat. I think everybody knows that all the hospitals in the Bay Area and throughout our country have been facing unprecedented negative financial pressures. This is attributable to many factors, including the impact of the Affordable Care Act, in conjunction with significant reductions in Medicare and other payer reimbursement, along with the proliferation of high deductible, high copay insurance products And like every other hospital, Washington Hospital is not immune to this negative business environment and must make the changes necessary in our spending to assure our ability to meet the healthcare needs of our community now and in the future. Nurses who work 12-hour schedules have enjoyed a very favorable pay practice at Washington Hospital, as they have been receiving 40 hours of pay for 36 hours of work. At one time, this was the market norm. The net result of this pay practice is that 12-hour nurses receive 11.11% increase in pay for each hour worked. It is also important to note that the hospital spends $2.9 million annually in additional compensation for 12-hour nurses who are paid in this manner. At this point, we're one of the only hospitals, if not the only hospital in the Bay Area, who has continued with this pay practice. Other healthcare organizations such as Daughters of Charity Hospitals, Kaiser, Hospital Corporation of America, and the Sutter Hospitals have ceased the practice of paying 12-hour RN for 40 hours of work when they only work 36 hours due to the excessive expense associated with this pay practice. In the current negative financial environment with lower reimbursements and fewer resources, it's clear that this practice can't not continue here at Washington Hospital either. And you might recall that we have a long-standing policy of meeting the market with regard to our pay practices. The market has changed. As other employees were being subject to a reduction in force here at Washington Hospital in September, our management team notified California Nurses Association that we can no longer afford the pay practice mentioned, and pursuant to the current CNA Memorandum of Understanding on this subject, gave CNA 90 days advance notice that this compensation practice was being discontinued. While we fully understand the desire to continue on with this pay practice, or to modify this pay practice with the hospitals paying RNs 38 hours when they work 36 hours, unfortunately, in today's environment, it's simply too costly to the hospital to continue on with either practice. As an alternative, hospital representatives have stated that the hospital is amenable to having 12-hour nurses work and be paid straight time for all the hours worked. In fact, several of our 12-hour nurses have asked Washington Hospital management staff if they could work 12-hour shifts and be paid at straight time. Hospital representatives have responded that this approach would work, but for any such proposal, it must come from CNA, as CNA is the bargaining agent for Washington Hospital nurses. This is not something the hospital can do unilaterally. To date, and to the disappointment of all, CNA has not presented any proposal to the hospital that encompasses 12-hour shifts at a straight time rate. If a proposal is presented to the hospital by CNA for 12-hour shifts to be paid at the straight time rate, the hospital will immediately consider the proposal and work with CNA so that 12-hour nurses may continue with the practice of working 12-hour shifts at the straight time rate. If we don't receive such a proposal, we will move forward with a plan for all 12-hour shift RNs to work 8-hour shifts. We're not asking for our nurses to take a reduction in their hourly compensation. What we're implementing will fully compensate our nurses for all actual hours worked, otherwise known as straight time.
Thank you. I must apologize in advance, for mispronunciation of this individual's name. Hussein Sarhain. Is he present here?
Yes.
Oh, fine. Would you, right there at the front, thank you.
But one thing I wanted to mention was the parking lot. When visitors come, the parking lot was taken on the northern side that was building a unit for joint reconstruction, something like that. And then another section of the parking lot was blocked for the physicians. At the meantime, while the population of Tri-City is growing, so you get more patients and more visitors and much fewer parking spaces. And you could be driving in that small space for circling that parking space for 15-20 minutes, and 3-4 people would be just fighting for this one parking space whenever it becomes available. I was wondering if you could find a solution for that, to maybe block a section for the physicians on this side. I was told to go park on this side, but not everybody's going to ask for a parking space, and by the time they're told, they'll be wasting another half an hour encircling that parking lot there. So these two things, if you could consider that. Thank you very much.
Thank you.
Mr. Sarai,
One moment.
Yes, ma'am.
I would ask you to make an appointment as soon as possible to come and meet with me in my office, and we'll work on some of the issues that you've brought up around parking and your mother. But I would like you to come and meet with me. Christine will give you information on how to contact me, okay?
Okay, I'll do that.
Yeah.
I would like to excuse myself now. Speaking of my mother, she's being discharged right now from the hospital. All right.
In the meantime, there is valet parking right at the front entrance,
The front entrance.
and
I'm
it's-
aware of that. I would like for the physicians and the employees to use that valet service.
Okay.
Thank you very much.
Thank you for your comments.
All right.
Let me just add, we are in the process of building a parking garage
It'll be in
on
the
the
back
property.
by Bart.
Right.
So we understand the issue, and that's why we're committing major amount of money to building a parking garage.
Oh, thank you. That would be great. It's through these venues like this, across the United States, in different institutions, that has made this country one of the best places on earth. And you're doing a great job. Thank you very much.
Thank you. Thank you very much, sir. The next speaker is Stephanie Howell. And I'd like to remind everyone there's a 3-minute time limit on the presentations. There you are.
Hi, good evening, everyone. We, the nurses at Washington Hospital, we're patient advocates. We are here tonight to stand up for what is in the best interest of our patients and our community. Nurses are the vital link in saving our patients' lives. Our community needs and deserves the highest quality of nurses at Washington Hospital, their hospital, to care for them and their families during their time of illness. Recently, after more than 26 years, management has decided to exercise a clause to end 12-hour shifts. Management has also insisted that we, the 12-hour nurses, cut our salary in order to make budget cuts that we feel that should not fall only on our shoulders. By seeking this change, the hospital is asking that more than 200 nurses suffer an 11% slash in pay. Washington Hospital is a magnet hospital. A magnet hospital is supposed to be a hospital where nurses have a high level of job satisfaction with low staff nurse turnover. Consumers rely on magnet designation for a reason. It's a credential for high quality care, but these proposed changes could place our magnet status in jeopardy. The action by Washington Hospital management could compromise patient safety, patient satisfaction, and nurse satisfaction, which again are the core elements of the magnet status. Many nurses have already resigned because of these two factors. Number one, the loss of the 12-hour shifts that we've had for over 26 years, and number two, the 11% pay cut. Nurses are leaving Washington Hospital. They're leaving because of dissatisfaction. Inevitably, nurse dissatisfaction equals patient dissatisfaction. It is imperative that nurses and management work together to obtain a fair and equitable agreement to maintain and improve patient care. Today, the nurses at Washington Hospital have voted to propose a 5.5% reduction in pay for the 12-hour nurses. We feel this is more than fair and equitable offer by the nurses. This offer, if accepted by administration, will result in a savings of approximately $1.5 million annually for the hospital. Reaching what we feel is a fair and equitable agreement will restore nurse morale. We sincerely hope that our efforts to reach out and work together will be reciprocated by the management and administration. We feel that everyone at Washington Hospital should participate to address the challenges we face. Shared sacrifice is a reasonable expectation if drastic changes affecting patients are occurring, and we're here tonight to encourage a team effort in order to provide the highest quality of care in the nation. Our patients are our families and our friends. They deserve a stable and highly skilled nursing staff with high morale. Furthermore, we feel this hospital, its nurses, management, and staff are equally family and should work together as one to meet the resolutions that the hospital as a whole is seeking. Thank you very much for your time.
Thank you. Do we have any other speakers? Okay, seeing none, I'd like to move on to our written communications from Dr. Peter Lenny.
Present the November medical staff credentialing action items. We had 3 new appointments to the medical staff. The first is Sarah Karamlu, a podiatrist. Next is Manuel Lamb, internal medicine hospitalist. And finally, Megan Swan, emergency medicine. For reappointments, we have Dr. Elizabeth Ady, OBGYN hospitalist, Dr. Sumitra Chari, internal medicine, Dr. John Dearborn, orthopedic surgery, Dr. Han Do, OBGYN, Vineet Kambaj, podiatrist, Dr. Roy Lin, pediatrics, Dr. Deirdre Lyle, OBGYN, Dr. Andrew Maxwell, pediatric cardiology, Dr. John Mehegan, vascular surgery, Dr. Satoshi Mitarai, intensivist, critical care, Dr. Baskari Pila, pediatric hospitalist, Dr. Gunjan Saxena, internal medicine hospitalist, Dr. Ranjana Sharma, family medicine, Christine Skolnick, registered nurse, first assist, Dr. Daniel Taylor, internal medicine, Dr. Anamali Virapan, gastroenterology, and Dr. Huang Vo, family medicine. Transfers in staff category, Dr. Jeffrey Carmel, dermatologist, is going from active to retired status, and Dr. Iraj Zandi, plastic surgery, is also going from active to retired status. For completion of proctoring and advancement in staff category, Dr. Bogdan Eftimi, hematology oncology, is going from provisional to active. Dr. Richard Long, urology, is going from provisional to active. Dr. Dale Tyler, ENT, is going from provisional to active. And Dr. Sharif Yasser, anesthesiology, is going from provisional to active. For completion of proctoring prior to eligibility for advancement in staff category, we have several folks who have completed proctorship. Sherry Armstrong, perfusionist, Dr. Lubna Hussein, emergency medicine, Dr. Dennis Martinez, emergency medicine, Dr. Sohail Sood, pediatric hospitalist, and Dr. Francis Wong, anesthesia. Resignations. We have 4 resignations of medical staff members: Dr. Andrea French, Dr. Young Lau, Randy Mastretti, PA, and Dr. Robert Manderberg.
Madam President, I move for approval of the credentialing action items as presented by Dr. Lenny.
Do I have a second?
Second.
All in favor? Christine, would you take roll?
Director Danielson,
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Dr. Stewart.
Aye.
Director Eaton.
Motion passes. Thank you. Gail, you're going to tell us about the results of the $5 jewelry sale?
first I'd like to tell you a little bit about, the gift shop elves decorated 11 Christmas trees that were offered in a drawing during the jewelry sale in the lobby of Washington West. And the response was great. Nancy, you won one.
It's beautiful.
Yeah.
It's in our office.
The gift shop was thrilled with the results. They were able to earn $1,200 and was going back to the hospital. Despite the inclement weather, the $5 jewelry sale was another huge success. I'd like to thank everybody for their help in getting the word out. That was really important. We had shoppers from Palo Alto, San Leandro, Milpitas, and San Jose, so it was amazing. Thank you to the hospital employees and staff for supporting this event in a big way. Our volunteers helped in a big way when the sale was expanded to 2 rooms on the second day. And I'd also like to thank the community for their help in making this a success. We were able to earn for the service league $19,936, which is the biggest sale so far. And we'll be going back to the hospital when we give our annual gift. And so both of the events with the money earned will be coming back to the hospital. So thank you, everybody.
Thank you for doing that for us.
It was fun.
Lots of fun, lots of work.
Yes.
And this was the first year that you actually expanded it
To
into
2 rooms.
those sections
Yeah,
here.
right.
And I knew it was going to be successful because I had to drive around for a while to find a parking place in order to come in here.
Well, we were worried, with the rain, that it would keep people away, but it didn't, so.
I saw small buses of people
Yes.
coming here in groups
Yes.
out in front of Washington
Well,
West.
thank God for everyone who passes out like flyers, emails people, and by word of mouth, because that's the way we get people to come and support the hospital. And most of them were thrilled and really excited, so they're looking forward to our next sale, which will be in May, 4th, 5th, and 6th.
All right.
Thank you, you really helped me with my Christmas shopping. That's great. Dr. Lunny, we're back to you with the medical staff report.
Current medical staff status is that we have 557 medical staff members, 333 active members, 102 provisional members, 67 with ambulatory status, 28 courtesy staff members, 3 consulting staff members, 21 allied health, and 3 administrative. There are currently 11 applications in process, 5 in the pre-application stage, and 6 with formal applications.
Thank you, thank you. Nancy, we have our hospital calendar.
Well, let's start with Joe and the phone piece.
Past health promotions and outreach events. Throughout November and December, Lucy Hernandez, Community Outreach Coordinator, presented 21 hand hygiene classes for students at Blakeow Elementary, Chadbourne Elementary, Durham Elementary, Forest Park Elementary, and Glankler Elementary schools, all located in Fremont. One hand hygiene presentation took place at Kitayama Elementary School in Union City. Information was provided on proper hand washing hygiene to prevent infection and the spread of germs. 464 students attended. On November 12th, Washington Hospital hosted a Rose Garden Remembrance event. This event provided an opportunity for the hospital community to remember employees, physicians, volunteers, and board members who have passed away while serving Washington Hospital. Dr. Edward Whalen and volunteers Bernadine Goulart and Jerry Kimball were remembered during this event. Michelle Heading, spiritual care nurse, provided non-denominational reflections. On November 14th, Dr. Alexander Saw, orthopedic surgeon, presented on treatments for hip pain. 23 people attended. Also on November 14th, Washington Hospital nurses and staff from respiratory care hosted a health fair at Kitayama Elementary School in Union City. Staff provided information on asthma, hand hygiene, and offered blood pressure screenings. 76 people were screened and 150 people attended the event. On November 15th, Washington Hospital hosted the 6th Annual Diabetes Awareness Health Fair. The event featured a health fair and presentations on complications of diabetes, insulin, and carbohydrates and diabetics. Presenters included Dr. Prasad Kata, endocrinologist, Dr. Archana Bindra, endocrinologist, and Anna Mazet, registered dietitian. 49 people attended. On November 18th, Dr. Gabriel Herskew, vascular surgeon, presented on varicose veins. 19 people attended. On November 20th, Dr. Albert Brooks, Chief of Medical Services, provided a birthing simulation for the students in Medical Explorers Post 539. The overall purpose of Medical Explorers is to provide worksite-based experiences for students ages 15 through 20 to help them pursue their interest in healthcare. The program has two components, which include scheduled monthly informational meetings and clinical rotations. At the monthly meetings, information is provided by guest presenters on topics such as scholarship opportunities and requirements, college preparation and planning, and options for financing collegiate education. In addition, professionals from a variety of healthcare disciplines provide information about the specific discipline and its role in healthcare today. On December 4th, as part of the Diabetes Matters program, Lori Roffelson, registered dietitian, presented Healthy Eating During the Holidays. 10 people attended. Also on December 4th, Michelle Heading, spiritual care coordinator, presented to the Tri-City Interfaith Council on Advanced Healthcare Directives, POLST forms, and end-of-life issues related to hospice and palliative care. 25 people attended. Upcoming health promotions and community outreach events. On Tuesday, January 6th, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, will be presenting Stroke Prevention and Other Disease Processes and Healthy Lifestyle, Be Smart and Avoid Stroke. On Thursday, January 8th, from 7 to 8 p.m., as part of the Diabetes Matters series, Dr. Sarbjit Hundal, ophthalmologist, will be presenting Diabetes and Your Eyes, Prevention and Treatment of Complications. On Monday, January 19th, from 7 to 8:30 p.m., Dr. Victoria Liebhart will be presenting Restoring Balance, a 4-week stress reduction program. On Friday, January 23rd, Lincoln Elementary School in Newark will hold a health fair for students, teachers, and parents. Washington Hospital staff will host a booth to provide health information and blood pressure screenings. The Washington Hospital Healthcare Foundation report. Washington Hospital Healthcare Foundation rang in the holiday season in early December with the Trees of Angels celebration, which raises funds for hospice care in the Washington Township Healthcare District. The festivities began on December 1st when the foundation partnered with the City of Newark to light the holiday tree at Newark City Hall. President of the foundation, Carol Dutra Vernacci, spoke on behalf of the foundation, and the Cougar Choralers from Newark Memorial High School entertained the crowd of 150 in attendance. On Wednesday, December 3rd, Carol Dutra Vernacci threw the switch to light the holiday tree at the Nakamura Clinic in Union City. Held in conjunction with the Union City Chamber of Commerce's annual holiday mixer, the tree lighting attracted 80 attendees. The James Logan Jazz Singers serenaded the crowd. Attendees stayed afterwards for a reception and raffle drawing. The foundation hosted the annual Children's Holiday Breakfast on Saturday, December 6th, catered by Bernard and Family McDonald's. The 375 attendees at this event enjoyed a magic show performed by Ronald McDonald. To cap off the morning, Santa and Mrs. Claus made a grand entrance and sat with families to have their picture taken. This year, the foundation invited Candango and Centro de Servicios in Union City to bring 200 low-income attendees to the breakfast so they could enjoy the festivities. On December 8th, Fremont Mayor Bill Harrison lit the angel tree at the Bernardin Family McDonald's restaurant at the corner of I-680 and Mission Boulevard. 120 district residents joined the foundation for the occasion and were treated to the seasonal music sung by the What the Dickens Chorus. The final tree lighting will take place on Thursday, December 11th. The event will kick off with the high school choral competition, which will begin at 5:30 p.m. in the Anderson Auditorium inside Washington West. The tree lighting will take place in the Washington West lobby immediately after the choral competition. The foundation would like to thank all of its sponsors for Trees of Angels, including Fremont Bank, Gonzalez & Kozenchenko, Professional Home Care Associates, and Keith and Verna Krugman. Special recognition is due to Mark Bernardin of Bernardin Family McDonald's, who has supported Trees of Angels since its inception 18 years ago. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District board members attended the Baywar grand opening on December 3rd. Baywar stands for Bay Area Women Against Rape. Previously, their only office was in Oakland. Their new second location at Washington East, 1900 Maury Avenue in Fremont, will allow greater access for those that live in southern Alameda County. Board members also attended the Newark Chamber of Commerce's annual holiday luncheon on December 4th. Washington Hospital Employee Association, WIA. WIA participated in the annual Drive for Warmth for the Tri-City volunteers to distribute to those in need. 5 barrels of coats, jackets, gloves, scarves, and blankets were donated by hospital staff and volunteers. During the month of November, WIA sold 326 gift certificates for See's Candy. The certificates were sold at a discounted rate to employees and volunteers. Washington on Wheels, WOW Mobile Health Clinic. During the month of November, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Ruggieri Senior Center in Union City, and Breyer Elementary School in Fremont. WOW also provided occupational health services, including influenza vaccines, to employees of Fremont Bank. The total number of community members receiving health care at the Washington on Wheels Mobile Health Clinic during the month of November was 238, with 195 receiving occupational health services. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was November's most viewed webpage with 12,805 views. InHealth, Channel 78. During the month of November, Washington Hospital's cable channel 78, InHealth, captured new programming, including a Diabetes Matters presentation titled Sweet or Sour, The Scoop on Sugar Substitutes, and 2 health and wellness seminars titled Treatments for Hip Pain and Varicose Veins. InHealth aired new programming including a Diabetes Matters presentation, What to Expect When Hospitalized with Diabetes, and a health and wellness seminar titled Treatment Options for Sleep Apnea, as well as the November Board of Directors meeting. Additional events. On November 20th, Washington Hospital participated in the California Department of Public Health statewide disaster drill to test the hospital's ability to effectively receive, isolate, and stabilize a patient suspected of having Ebola and work with county and state agencies. Specifically, hospital staff focused on testing communications, including public information and warning, command center management, dealing with a medical surge, and public health epidemiological surveillance. The drill lasted from 8 a.m. to noon and included staff from all areas of the hospital. On December 5th, students from Fremont Christian School's ARK, American Cancer Society Club, delivered Christmas cards for patients undergoing cancer treatment. ARK stands for Acts of Random Kindness. They are a service club who performs charitable services for cancer patients. For more information on any of the programs mentioned, Visit WHHS.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
Before I get to the announcement of our Employee of the Month, I wanted to cover a couple of things with you this evening. The first is that Healthgrades has named Washington Hospital Healthcare System among the top 5% in the nation for its commitment to clinical quality and superior patient outcomes. Healthgrades is an independent third-party organization that rates hospitals based on objective measures of performance. Healthgrades measures 40 million patient records from 4,500 hospitals nationwide for the most recent 3-year period. Washington Hospital is the recipient of Healthgrades' Distinguished Hospital Award for Clinical Excellence. As you're aware, we're constantly working to improve patient care, clinical quality, and overall patient outcomes, which is why we review all external assessments of the care and service we provide to our community. This type of public reporting of quality indicators provides an independent third-party assessment of the care provided to patients. And I want to make sure you're aware that it is out there for our community to review and consider when making a decision about where to receive care. We do not have a licensing agreement with Healthgrades this year. The cost was prohibitive, and given the reductions in expenditures that we have brought forward, I didn't think it was appropriate to make those payments when everybody else is being asked to tighten their belt. So because we don't have a licensing agreement, it means that we can't advertise or market this award or recognitions that come from Healthgrades. The agreement with Healthgrades does require a significant financial investment that we did opt not to make this year. But I wanted the board to know that we have been recognized as being in the top 5% in the country, which is pretty special. I'm very proud of everybody that's contributed to that. Our employees, our volunteers, our medical staff, the leadership of this hospital. It's a nice achievement for us, a good Christmas present. I also wanted to mention that Prime Healthcare, which is waiting in the wings to buy Daughters of Charity hospitals, has announced its plans to go public by the year 2017. The union, FCIU, United Healthcare, has been taking Prime Healthcare on in the courts. The union has filed a lawsuit against the Daughters of Charity healthcare system, alleging the system evaded federal pension law, and further alleging that the futures of 9,000 employees and retirees are at risk because Prime had not agreed to operate the pension plan as one protected by the Employee Retirement Income Security Act. They have also accused Prime of overbilling Medicare by $93 million. Prime's answer to that is that these accusations are based on fabricated data and has described the allegations as part of a tired, self-serving corporate campaign the SEIU UHW is waging against Prime. Our Attorney General, who has to approve this transaction with Daughters of Charity, has yet to take a position. I also wanted to announce that we are still awaiting the state of California's approval for our plans for caring for Ebola patients. They entail keeping these patients in the former outpatient cath lab building, which has its own independent air handling system and is physically separate from the hospital. We still haven't heard thumbs up or thumbs down. Yesterday in the news, I saw a physician who is a survivor of Ebola and who is an American citizen talk about post-Ebola syndrome, and that was the first time I had heard about this. They're beginning to see a lot of people who survived Ebola develop vision problems. They complain of clouded vision, and for others, the visual loss is progressive and leads to complete blindness. They are also complaining of body aches, chest pain, headaches, and fatigue on an ongoing basis. So the medical community is beginning to define what the post-Ebola syndrome is. Apparently, you aren't out of the woods if you've survived. There's still more to deal with. I also wanted to make sure the board was aware that the county supervisors in Contra Costa County have made a $12 million allocation to the West Contra Costa Hospital that we've talked about on and off in this meeting. It's Doctors Medical Center. It's a former hospital district, once known as Brookside. So they have come up with an additional $12 million in the hopes that they might stay open as a full-service facility at least for a few more years. Also want to make sure the board was aware that the House Republicans have sued the Obama administration over the Affordable Care Act, and the lawsuit is very narrowly focused. It's on the administration's decision in January of 2013 to postpone the employer mandate to 2015. The employer mandate requires businesses with 50 or more employees to provide health coverage to their full-time employees or pay penalties. The lawsuit also addresses the Obama administration's decision to further delay the employer mandate for businesses with 50 to 99 employees until 2016. The lawsuit alleges that President Barack Obama gave $175 billion to insurance companies in violation of the law. And that is in the form of subsidies to help low and middle income people pay for their health insurance premiums. So it's going to be an interesting process as that piece of the law is challenged. I also wanted to announce that our public hospital, Highland, has named one of its own to be an interim CEO while it seeks a new leader. Daniel Bogan Jr. is going to take the helm, replacing Wright Lassiter. This will happen on December 15th. Wright is leaving for a job with Henry Ford Health System in Michigan. Bogan, who's 68 years old, served on the Health Systems Board of Trustees from 2005 to earlier this year, and was a member of the search committee that hired Lassiter. So they're moving along with a job search for Highland. And now, it's my pleasure to announce our Employee of the Month, Ruben Sanchez. He is an environmental services aide. He is our December Employee of the Month. He's been a dedicated environmental services team member since August of 2011, confidently working in a variety of area assignments, tasks, shifts, and he's been lead for environmental services. Prior to coming to Washington, he was a security officer appointed here on our campus for 2 years. So we got to know him a little bit before he found a job with us. He's been described by his coworkers as an employee who has energized the team, enhanced morale, and has always supported the department and the hospital. To express their appreciation, Ruben's coworkers had collectively nominated him for the December Employee of the Month. That's a pretty big honor to have your coworkers come forward with that. While he's away from the job, he's also very energetic and enthusiastic among other activities including fitness training, boating, snowboarding, automotive repair, fishing, and relaxing with his wife and friends. So we're very, very proud of Ruben and congratulate him on this achievement.
I see here that we are about to hear a construction report from Ed Fayan. Nancy, would you?
Yeah, I think everybody knows him.
Okay.
Thanks, Pat. I have a brief report today. So first on the parking garage, we have, since the last meeting, closed off the parking lot that's going to be affected by that, fenced it off. Been removing things like the parking lot lights and the other assets that are there, and then we are going to start to remove asphalt, concrete, things like that that are out there in preparation for the start of construction. We also learned last week that we had new assessments from the city of Fremont for permit fees, so we are in the process of getting those paid this week. And then I think you can look next week for an imminent start of major construction activities. So that's where we are with the garage. On the Hyman Pavilion, I reported last time that we had gone through a bidding process for the first group of contractors that had to do mostly with shoring and concrete work. Those contractors or subcontractors have been awarded, and they are now going through the process of their submittals through OSHPD. So that's what's happening right now with them. In the meantime, we have continued bidding and finished pre-qualification of all the other major subcontractors. And the good news is that we got coverage of 3 or 4 subcontractors for all of the major trades through the pre-qualification process. It is very competitive out there, and so we're going to be staying tuned to that and making sure that we get bids in from all those guys, because they are being solicited for a lot of work. There were 2 or 3 trades that we only had 2 people pre-qualify, things like elevators, but I think we're in good shape. So the bidding for that should be completed at the end of January, first couple of days in February, so we'll be back at that time to report on where we are with those bids. And that's my report, unless there's any questions.
Thank you. Good to hear.
Stay tuned for January. We really should start to have, and I've decided that what brought the rain was we've started construction. That must be it.
But we can't complain.
No.
Because we need the water. We're kind of caught.
It's going to be messy digging.
Yeah, it could be, but maybe they'll have fun in the mud. Thank you. We now have our quality report. Nancy, would you do the
Mary
honors,
Boland
please?
is going to be presenting. I think everybody knows Mary at this point.
Thank you, Pat. Good evening. Tonight I wanted to give an update on our quality IHI dashboard for quarter ending 9/14. We're going to start off with some of the core measures and talk about the compliance with those. In this quarter, we did have 2 cases of aspirin that fell out at discharge, and PCI case, just 1 case where the patient got into the cath lab in greater than 90 minutes. Otherwise, the statins are above benchmark. Evaluation of LBS function is 100%. Our ACE and ARBs, we're working on getting those monitored more closely to make sure that everybody's getting an ACE and ARB at discharge. These are patients who have heart failure. We've got a task force working on that. That's looking better for the months afterwards. Pneumonia is doing well, greater than about right at 94%. This is just making sure that we're choosing the right antibiotics to give patients who have been diagnosed with with pneumonia. Excuse me. Our surgical care improvement project is doing well. We're all within compliance, except for 1 antibiotic that went a little over what CMS likes us. They like these to be discontinued within 24 hours. This one was extended for a greater period of time, which was clinically appropriate in this case, but we just we're missing a little bit of the documentation with that. And the rest of the skip is doing good with beta blockers, monitoring patients who have cabbages, looking at their glucose, all that's with above the benchmark, and looking at monitoring how these patients' catheters are removed is also greater than 98%. Antibiotic timing for hospital outpatient surgery, greater than the benchmark, and also with the antibiotics we're selecting. So what is referred to as HOP is looking really well in core measure compliance. Moving on to our infection prevention indicators, central line associated bloodstream infections continues to be under the benchmark. That is a benchmark that's provided by the CDC. We did have 3 cases, but again, that's lower than the national rate for central line infections. And for surgical site infections, we continue to do really well with this. We've been under the benchmark since even greater than 613. We only had 2 surgical site infections, one with a fracture and a cesarean section. Our C. diff, I know this group has heard a lot about what we're doing with C. diff. Even though we're still above the benchmark, you can see that it's starting to go, or has continued to go on a decline, which is great. It's 1.4. As you know, there's a lot of interventions around this associated with cleaning, looking at antibiotic use, our hand hygiene program. I think all these factors are starting to come together, and luckily we're in a downward trend. We still continue to meet with the C. diff task force, and so we're happy to see this result. Catheter-associated urinary tract infections are also below benchmark. We did have 3 last quarter, but that's putting us at 0.69, which is less than expected by the CDC. And our hospital-acquired MRSA bloodstream infections, these would be patients that acquire MRSA in their blood. We did not have any cases, and that's the 2nd quarter in a row, so that's great news. And for the VRE, same thing, 0 infections acquired here with those, and that still puts us at below the benchmark by CDC. Our nursing sensitive indicators, looking at patients who can develop a pressure ulcer while they're here in the hospital, we only had 1 last quarter, putting us at below the benchmark. That's a CalNOC benchmark that we use, so we're doing better than that. And when we look at patients to try and reduce the risk of them falling, you can tell this is been getting better. The last one was 0, we didn't have any falls. So that's doing well below the CalNOC benchmark. Moving on to the Joint Commission National Patient Safety Goals. As far as our handoff communication in between shifts about making sure that everything about the patient is expressed in an SBAR format, it's continued to do really well. We're doing 100% compliance there. And same with patient identification. All of the standards that need to be met to make sure that we're giving things to the proper patient, it's about 100% compliance. Procedure timeout, same thing, 100% compliance with making sure that that safety measure is in place prior to all procedures. Hand hygiene, you can see the 3 months broken out here, but roughly always above 90%. It's closer to 96.3. September is reflective of about the average of where it's been. We're still really focusing on this Joint Commission Targeted Solutions tool. We still have infection prevention working closely with all areas of the hospital to make sure that the hand hygiene is occurring, and that when it isn't, we're following up really quickly with these people and meeting and taking the appropriate steps to make sure that everybody recognizes what a priority it is. That's a big success in the realm of hand hygiene when the national average is closer to 50-60%. Looking at our readmission rates, Medicare, just the Medicare group, looking at patients with pneumonia who are readmitted, you can see that there has been an incline on this, so we're taking these cases and looking closely to see, if there's any trends or causes. Right now, we have not been able to find them. There's they look at all causes, all the patients that come back who, within 30 days, who had pneumonia. And these are cases that we'll look closer at and look about trying to how to prevent them in the future. Medicare heart failure readmissions.
Mary, they're not coming back with pneumonia, they're coming back.
Yeah, so the interesting thing about this is that when you drill down on these cases for July, August, and September, you can see there, so July you had 3, August there were 2 out of 4, and September 3 out of 5. When we looked at these, let's say, for example, one patient had fallen, they had to come back to have surgery on their hip. Another person had a urinary tract infection that wasn't related to the pneumonia. We had a couple that had a respiratory issue that was similar to the pneumonia, like a couple of these patients had COPD, but again, not a real trend on we missed something with their pneumonia, so therefore they came back in 30 days. So it's kind of scattered. It's a really good point.
But Mary, it's still counted as a readmission, even
Yes.
though I want to make sure that everybody
Fortunately,
understands that
it is.
the pneumonia is what's triggering it, but pneumonia is gone. But they come back in for another, maybe unrelated condition.
Exactly, so all cause.
Yeah.
Yeah, so it's regardless of whether or not they're here for pneumonia, then the next 30 days something happens, like this example where this patient fell, came back, counts in the readmission data.
Thank you.
And they're also looking at all payers, not just Medicare. We're showing Medicare here, but Medicare is looking at all payers also, so. And I mentioned heart failure. better, right under the benchmark. 3 patients in September, 4 in August, and then 2 in July came back who had had heart failure. Same thing when you drill down on these patients. There was patients that, this is about 50% of the patients did come back with heart failure related issues, which is common in this group of people, but the other ones were not related to the heart failure. Looking at patients who had an AMI and then came back in 30 days, slightly above benchmark. We did have 2 out of 6 patients in September. We didn't have any in August, and then going back to July, we had 3 out of the 7. And that's it. Any questions?
Thank you. Questions? Thank you. Finance report. Chris Henry is up.
Okay, good evening. Tonight we'll be looking at Washington Hospital's operations and financial results for October 2014. And we'll jump right into our operating indicators. Average daily census for October was lower than budget by 6.7 at 151.5. We had 997 admissions during the month. We had expected 1,010, so we were about 13 off on that number. Patient days for the month were 207 below budget at 4,697. Our outpatient observation equivalent days, though, were 101 above the budget at 289. The average length of stay for the month was almost right on budget at 4.82. We'd expected 4.86. Looking at the case mix index. Case mix index for October lower than we've seen at 1.404. We did take a look at this. We really saw this occurring as a result of lower severity of our cases in our neuro and cardiac surgical lines. We had much lower lengths of stay with our neuro and cardiac cases. We looked at the DRGs. Those two types of surgeries really impact this number and really brought it down for the month. Deliveries for October continued to be higher than we've seen at 170. We expected 153 in October. Our surgical cases were 7 below the budget at 368. That included our joint replacement cases that were just 1 below the budget at 117. Our neurosurgical cases for the month, although lower severity, there were more of them. We had 5 more than expected in the budget at 34. And likewise, our cardiac surgical cases were 7 above the budget at 16. Cath lab procedures for the month came in 27 above the budget in October at 687. Our outpatient visits for October came in at 7,910. We'd expected 8,140 for the month. The emergency room, again, continued to be busy in October with 4,416 visits against a budget of 4,193. Quick look at the cath lab activity. Again, during the month, our peripheral vascular procedures continued to dominate the activity in the cath lab, followed by cardiac procedures at 34%, and then the rest filled in with our non-vascular and our neuroradiology procedures. Looking at our FTEs for the month, we had for October 1,179.5 productive FTEs and 149.2 non-productive FTEs, giving us total FTEs for the month 54.4 above the budget at 1,328.7. Our FTEs per adjusted occupied bed, which is our productivity measure for the month, came in at 6.32. Although I do want to note that our productive FTEs per AOB in October were much closer to the budget at 5.61 versus a budget of 5.54. So we did flex to the activity. Those folks ended up out on ETO, and so that drove the total FTEs higher than expected. But productive was pretty much right on budget. Jumping into the financials, total patient revenue for the month came in $732,000 below the budget at $171,354,000. Our contractuals for the month came in at 76.48%. a bit higher than our 76.34% that was expected. And as we get down to bad debt, you'll see we continue to see that shift, moving up to Medi-Cal, and Medi-Cal continuing to grow, particularly in the HMO product, which is where a lot of the expansion is occurring. So we end the month with net operating revenue about $386,000 below budget of $40,484,000. Operating expenses for the month came in almost $1.5 million below budget at $38,002,000. Largest part of those variances came in the areas of benefits. We did have lower health and welfare benefit costs in the month of about $1 million, and those costs can be very volatile during the year. Health and welfare claims are really unpredictable and can go from one month to the next. So it's something we watch during the month. So it's something we'll continue to watch during the year this year and see how that trend develops. The other areas where we saw variances were in professional fees. We did have some higher costs related to our ongoing union negotiations in November and professional fees related to our higher volume in the ED. Bad debt for the month was also about $1 million below budget, and again, that's that shift going up to, you saw our higher contractuals result lower bad debt. It's the shift going from private pay. Those folks who in the past would have been on their own are now finding coverage through Medi-Cal, and we're finding a lot of those people are getting coverage well after the fact. So we've had cases open for as long as a year where folks are finally getting coverage from Medi-Cal. So they're moving slowly, but they're moving. So we end October with a total bottom line of just under $2.5 million, about $1.1 million above the budget. Non-operating income for the month came in $192,000 above the budget at $1,283,000. That included an unrealized gain on our investments of $246,000. Kind of interesting watching what's going on with the markets and in fixed income securities right now. It's kind of hard to predict where they're going to go. So for this month, we'll take the gain. We end up with a total bottom line of $3.765 million for October. So a fairly respectable month for the healthcare system. Take a quick look at our Financial Accounting Standards Board. We just looked at our Governmental Accounting Standards Board presentation, which is the way we produce our financials for audits. This presentation is representative of how financial markets might look at us. Our bottom line from operations stays the same at $2.482 million. We pull our property tax revenue that supports our general obligation bond debt and our unrealized gain on investments out of non-operating income to end up with non-operating income from a FASB perspective of $253,000 and a total bottom line about $1 million above the budget at $2.735 million from a FASB perspective. So are there any questions on October?
Thank you. Nancy?
I'm here to give the preliminary results for November, which aren't going to be as dazzling as the preceding month, but they're still reasonably sound. We saw 952 patient admissions in November. We had an average daily census of 151, and this was 2 lower than we had budgeted, and 2.6% below the budgeted average daily census of 155. By comparison, the average daily census recorded last year was 154. It was still pretty close. The high and low census ranged from 171 down to 112. Our outpatient observation equivalent days of 247 were higher than the budget of 191 by nearly 30%. The state has given us approval to open the observation unit, and I'm in the process of finalizing the staffing plans for physician leadership for that unit. And as soon as we get that squared away, we'll be able to get the unit open. But we have state approval to operate it, and once that occurs, the length of stay in the observation unit will be 24 hours, and a decision will have to be made about the patient's admission or the decision to send them home. That I hope to address that problem squarely in the very near term. Average length of stay based on discharges in November was lower than we had budgeted. It came in at 4.45. And this is lower than October's average length of stay that was budgeted at 4.82. So we had 6 patients with a length of stay greater than 30 days in that mix, which is something we've also had begun to watch pretty carefully. The birthing center saw 149 deliveries in November. We had budgeted 140. Last year we had 142. In terms of surgery, our volume is down. We had neurosurgeons absent from the hospital going to national conferences. And we also had our interventional radiologist, Dr. Bruce Lynn, away for 22 days. That has definitely affected our surgical activity. We had 325 cases, 9 below the budget. We had cardiac surgical cases that were 4 above budget, neurosurgical cases that were 10 below the budget, which reflects their absence at national meetings, and joint replacement cases that were on budget exactly at 110. All general surgery cases were below budget by 3. Inpatient surgical activity was below budget by 19, while outpatient surgeries did come in above budget by 10 cases. 590 cases were seen at the outpatient surgery center. We had budgeted 573, so they're continuing to significantly exceed their budgeted numbers, which is very good. For the month of November, the total procedures seen in our cath labs were 457. We had budgeted 561, and here you can see the effect of Dr. Lynn not being present. Our cath lab volume for November a year ago was 531 procedures. So you can see it's a significant drop. Cardiac procedures were 11 below budget, and peripheral vascular procedures were 34 below budget. Neurointervention procedures were 26 below budget. Our non-vascular and other procedures were 33 below budget. Overall, inpatient cath lab procedures were 101, or 34.9% less than anticipated. And the outpatient procedures were 3 fewer than anticipated. Outpatient visits for November totaling 6,576 were 619 lower than the budget, and lower than November a year ago. Emergency room recorded a total of 4,175 patients, a daily average of 139. They came in 183 visits above budget, or 4.6% positive variance. Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,300 patients during November, 153 less than they had budgeted. Our total system emergency room and clinic visits for November were 7,475, pretty close to what the budget was at 7,445. In terms of personnel, we had 1,311.4 FTEs, including 13.8 agency personnel, mostly associated with IT, as we begin to prepare for the 2014 upgrade. This was 0.6% higher than our budget. Productive FTEs per adjusted occupied bed came in at 5.62. The budget called for 5.48. Let's see, run through that and go to patient mix. The inpatient revenue for the month of November amounted to approximately $111.1 million, compared to the budget estimate of $121.9 million. Of this amount, 55.1% was Medicare, including Medicare HMO, and 21.4% was Medi-Cal. So you can see the Medi-Cal is truly beginning to creep up. This compares with budgeted inpatient revenue percentages of 57.2 for Medicare, so it came a little bit lower than we expected, and 17.1% for Medi-Cal. We came in higher than expected with Medi-Cal. Not necessarily a very good thing because Medi-Cal is such a poor payer. Let's see. Total government program revenue for November comes in at 76.5%. It's just not a healthy balance. We had budgeted 74.3. Based on November's 4,530 patient days, 54.7% were Medicare, 22.5% were Medi-Cal. We talked about how they compare with budget. Inpatient revenue for the month was under budget by $9 million, or 7.5%. Outpatient revenue for November was above budget by $2.2 million, or 5.5%. The inpatient revenue variance is due to the lower census in the cath lab, which drove lower utilization of ancillary services. Outpatient revenue was higher than budget due to the increased activity in the operating room and emergency rooms. So in summary, we had 2 less admissions and 108 less inpatient days than we had anticipated in the budget. Surgical cases were below budget by 2.7%. Cath lab procedures were below budget by 18.5%. That's nearly 20% reduction. For the month of November, our outpatient visits for November came in at 8.6% below budget, and ER visits were 4.6% higher than anticipated. Our clinic visits for the month were below budget by 4.4%. Our total paid FTEs were above budget by 0.6%. It's a pretty good result, and below the last 12 months average by 46.8 FTEs. Our FTEs per adjusted occupied bed were below budget. Inpatient charges for the month were below budget by approximately $9 million. Outpatient charges were higher than budget by approximately 2.2. So our total hospital charges for November are going to come in below budget by approximately 4.3%, or $6.8 million. On November 30th, there were 177 days cash on hand. The total days revenue and accounts receivable at November 30th was 67.5. The days revenue and accounts receivable excluding Medi-Cal was 66.5. Days in accounts receivable excluding the Alameda Alliance, which is still an issue for us, was 54.7. During the month of November, $1,063,096 of charges were approved for pending charity assistance.
We have several action items to deal with this evening. We need a motion on resolution number 1151.
Yes, Madam President, item A. I move for adoption of resolution number 1151, which is the memorandum of understanding between Nancy Farber, Chief Executive Officer, authorized representative of Washington Hospital, and the United Healthcare Workers West, Local 250 SEIU/UHW, a recognized majority representative under the terms of Board Resolution number 331A, effective December 10, 2014.
Second.
Can I give you a summary of what's
Please.
in this agreement?
Please.
Negotiations began in May this year, and we concluded in October, the end of October. The contract was ratified by the membership on October 28th. The term of the memorandum is from July 1st, 2014 to June 30th, 2017. It's a 3-year contract, and the contract was negotiated with no reopeners. The membership covered is 469 employees, and that number is as of October 30th this year. Highlights of the key financial items are, across the boards, on July 1, 2014, a 1% across the board payment. January 1st, 2015, another 1% lump sum payment. July 1st, 2015, an across-the-board, 1% across-the-board payment. January 1st, 2016, a 1% lump sum payment. And July 1st, 2016, a 1% across-the-board payment. Key contract additions include clarification of per diem employee scheduling, consistency in on-call payments, greater flexibility of benefit choices, and I'll talk about that in a minute, and it places the hospital closer to the market in terms of wages and benefits. As with CNA, the issue of us meeting the market is a significant challenge because we have great longevity, which I believe is a strength of the hospital, but it also makes it tougher when the market is receding and we don't. And it's a big pressure for us. I wanted to talk about the flexibility of benefit choices. We had introduced the idea that people would make a modest copay for family members that are on our plan. I believe the union wanted to be able to say that they provided benefits to their employees with no benefit costs. The way that was achieved was their proposal that we introduce a second plan that would be available to employees, which is a high deductible, high copay plan. The very thing that bedevils us financially and causes such difficulty in relationships with our patients, because patients come believing that they are covered only to discover that they have enormous deductibles and copays in these plans that are cost prohibitive. And in fact, the literature in healthcare has begun to reflect what you would expect would happen, which is patients defer getting care until it is almost too late, and there's an increase in the number of patients that are far sicker than they would have been if they had come on a timely basis when they first needed care. I have a particular deep and profound antipathy for these plans. Families buy into it believing that they're never going to get sick. And then suddenly a family member does get sick, a child or a parent, and they're faced with a horrible, horrible financial consequence. And I just don't believe that should be part of what we offer. We'll be talking about these benefits later in 2015. Blue Shield is looking at whether or not they can administer something like this for us. But we'll be having brown bags about what this plan does and doesn't do. I am very sorry that they believe that this is necessary. When you compare the nominal amount that we're asking of our employees to contribute for their family coverage, it is so below the market, it's astounding. And I can't believe that anybody would choose a plan like that in lieu of the very generous benefits that we provide now, but that's what the union wanted to be able to say. So this is part of that agreement, and here we go. So my recommendation to the board is that they do ratify this agreement and give me permission to execute the contract.
Okay, we have a motion and we have a second. Christine, would you take a roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Eaton?
Aye.
Motion passes. Thank you. Our second motion.
Item 8, Madam President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts and proceed with purchase of Epic perpetual software licenses for a total amount not to exceed $1,238,050. This is an approved project in the 2015 capital budget.
You have a second?
Second.
Nancy, do you have anything further to add on this?
IT. We executed an agreement with Epic Systems Corporation in December of 2010, which granted the use of a license for Epic software for a 4-year term. This license term is now coming to an end, and the agreement allows for a conversion of the license to a perpetual license. The perpetual license will enable the hospital to continue using Epic software under the terms of the licensing agreement. By converting to a perpetual license, we continue our investment in utilizing Epic software within the healthcare system and enable future upgrades and software module implementations that we hope will enhance patient experience and improve the efficiency of our operations. I'm requesting the board approve this.
Thank you. Christine? Dr. Danielson?
Aye.
Director Wallace?
Aye.
Dr. Nicholson?
Aye.
Dr. Stewart?
Aye.
Dr. Egan?
Motion passes. Thank you. Our next item.
Item C, Madam President, in accordance with district law policies and procedures, I move that Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase of the Dragon Medical 360 Network Edition speech recognition software and implementation services for a total amount not to exceed $97,162. This is an approved project in the 2015 capital budget.
Second.
Thank you. We have a motion and a second. Oops. Nancy, would you explain what Dragon Medical is?
This allows the doctor to dictate into the computer system, and the computer hears it and prints out what the doctor's saying. Key benefits of the Dragon Medical 360 implementation would include the ability to dictate directly into Epic with full text box control using something called VSync. Over 1,000 voice commands for navigation within Epic. Improved medical vocabulary over the prior edition of Dragon. And roaming profiles that can be accessed by any computer in our network. Take about 3 months to fully complete this. And I believe it will make a big difference to the physicians. I don't know if you have anything to say about that, Dr. Lunny?
I don't personally use it, so I'm not that familiar with
Okay.
it. I understand the concept behind it, and that there probably are a significant number of our physicians that will benefit from that.
I think, they speak instead of typing. And some of our doctors have taken to the typing like a duck to water, and others never will. So this is a good thing.
I think there's some significant potential benefits that we can derive here. As you noted, not all physicians are touch typists, and some are better than others and faster than others. And in the medical record, it's important to have comprehensive narrative information, and I think with the ability to dictate and have it immediately transcribed, we'll have better narrative information that's entered into the system by the physicians, and more narration as far as the assessment and plans that we can communicate more effectively with our colleagues. One of the absolute benefits of an electronic medical record system is the immediate access to the notes of other providers. And we want those notes to be as effective and comprehensive as possible. And sometimes we do well, and I see Dr. Lunny shaking his head and say sometimes we don't do as well as we ought to. So hopefully this system will allow us to make strides with that. I know the radiologists are working with Dragon presently, and they're making progress.
I think Dragon has also improved quite a bit over the years.
Oh, yes.
And it is able to handle a number of accents and variations in how people speak.
I think this will be a work in progress.
I sure hope that we benefit from it.
continued work.
Exactly.
All right. Okay, we have a motion, we have a second. Christine, would you?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Eaton?
Thank you. We have another,
Item D.
yes.
Madam President, in accordance with district law, policies and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase of hardware, software, and implementation services to include Epiphany Electrocardiography Management System, FormFast on-demand form printing, Styx Employee Health Management, PACS Cubes Imaging Distribution System, Seaboard Patient Nutrition Services System, and Accelera Cardiovascular Image Management System, for a total amount not to exceed $323,224. This is an approved project in the 2015 capital budget.
Second.
Thank you. Nancy, would you
Yeah,
describe
when we were
these,
putting
please?
Epic in, we made an important decision, which was that upgrades to other systems were delayed to ensure a stable environment for the Epic build and to maximize utilization of limited resources that we have to get all of this done. So everything was kind of frozen in place until we had a stable system. And now we need to do the upgrades so that we don't lose vendor support and that we meet all our compliance requirements. So this is the catch-up. On Accelera Cardiovascular Image Management System, this upgrade is going to support 3D transesophageal echocardiography equipment that we purchased already. And it's an important addition to the clinical abilities of the hospital. The Seaboard Patient Nutrition Services System that upgrade would allow improved management of glucose protocols. And everybody knows that diabetes care is a big, big issue, and that we have a large population of diabetic patients in the district, and that this is a very relevant improvement for them. So there are any number of reasons why we want to do this, and I would recommend to the board that they pass these upgrades.
We have our motion, we have our second. Christine, would you poll the board?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Eaton?
Aye.
Motion passes. Thank you. We will now adjourn to a closed session. We are reconvening, and I'd like to report that no reportable action was taken during the closed session. This meeting is coming to a close, and I would like to wish everyone a Merry Christmas, Happy New Year, and happy all of the other holidays that occur at this particular time of the year. Thank you. This meeting is now adjourned.